So during this lecture, we will talk about small and large intestinal pathology. The small intestine and the large intestine form a large part of the gastrointestinal tract. The small intestine is formed, as you know, from the duodenum, jejunum, and the ileum. The large intestine, as you know, is formed of the cecum, ascending colon, transverse colon, descending colon, the sigmoid, and the rectum. And they are the site for many inflammatory, malabsorptive, and even neoplastic diseases. The small intestine and large intestine are formed histologically from the same cell tissue layers. They are formed of the mucosa, submucosa, muscularis propria, and the serosa. However, this wall thickness is thin in the small intestine while it is thicker in the large intestine. However, the lumen of the small intestine is narrower than the lumen of the large intestine. So we have a long list of diseases that can affect the intestines, whether the large intestine or the small intestine, and they are subdivided into these subcategories. Intestinal obstruction, which is a very common manifestation seen in the emergency rooms, sometimes in kids and in adults. Vascular disorders, in which we will discuss one of the commonest diseases of the gastrointestinal tract among patients, which is hemorrhoids. And we have the malabsorptive diseases. You know that the small intestine is the main site for all nutrient absorption. So diseases that affect the small intestine can result sometimes in malabsorption. And we have also the infections, and the infections will be covered in the microbiology section, not in the pathology section. So during this lecture, I will cover the intestinal obstruction and its causes, vascular disorders, and malabsorptive diseases resulting in diarrhea. Inflammatory bowel diseases will be covered in a separate lecture, and the polyps and neoplastic diseases also will be covered separately. Intestinal obstruction is an important disease, and it is subdivided into mechanical obstruction and non-mechanical obstruction according to the underlying cause. It's just like the mechanical and non-mechanical obstruction that we discussed in the esophagus. The mechanical obstruction is caused by intussusception, hernias, adhesions, and volvulus in about 80% of the cases. We will discuss intussusception in details. The remaining cases are caused by tumors or sometimes by diverticulitis or by an infarction. Non-mechanical obstruction also can be caused by Hirschsprung disease, which is an important disease you have to know about, neurological disorders, and even drugs. Sometimes a paralytic ileus following a surgical procedure is also categorized under the umbrella of non-mechanical obstruction. It is important to know the clinical picture of intestinal obstruction. When you have an obstruction to the passage of a stool in the intestine, and the most common site for intestinal obstruction is usually the small bowel. It is more commonly affected than the large bowel because of the small diameter of the lumen. The symptoms are predominated by abdominal pain and distension due to gaseous distension. In addition, the patient is also complaining of vomiting and constipation. And intestinal obstruction can present as an acute problem of sudden onset, like in the cases of intussusception or volvulus or infarction, but it also can present as a chronic, long-standing problem, like in the cases of Hirschsprung disease or in the cases of tumors. So here in this picture, you can see the most important or the most common causes of mechanical obstruction that are seen in 80% of the cases, which are the intussusception, the herniation, adhesions, and volvulus. Intussusception will be covered in details in the next slides. And it is usually seen in kids or in children. um, Hernia, or what we call it الفتق, it is a protrusion of the bowel segments and its mesentery through a defect in the usually in the abdominal wall. We have umbilical hernia, femoral hernia, inguinal hernias, and in all of these, a part of the bowel is trapped in the hernial sac, and there will be obstruction. And in some cases, it will be complicated by infarction of this bowel segment. Adhesions, the adhesions is التصاقات, which can occur between bowel segments, and usually it is a complication of a previous inflammatory condition in which there is a scarring after the inflammation, and sometimes after surgical procedures at the sites of previous surgery, complicated by fibrous scarring and adhesion between two bowel loops. This adhesion will result in mechanical obstruction. Another cause of mechanical obstruction is volvulus. Volvulus, or it's like torsion of the intestine, التواء, in which we will have impaired venous drainage, stasis, edema, and congestion, and can be complicated later on by infarction and ischemic damage to the bowel. So what is intussusception? Intussusception is the most common cause of intestinal obstruction in children under the age of 2. And it happens when a segment of the bowel that is constricted by a wave of peristalsis telescopes or enters into an immediately distal segment that is wider in its diameter. So a constricted segment enters or telescopes into a wider distally located segment, and with each peristaltic contraction, the proximal segment enters more within the wider distally located segment and is propelled by these peristaltic contractions, pulling with it the mesentery surrounding the bowel. If left untreated, the intussusception will progress to infarction. So again, intussusception is the most common cause of intestinal obstruction under the age of 2. And in most of the cases, it is idiopathic, meaning that there is no underlying cause. However, in other cases, the cause is usually lymphoid hyperplasia, that is Bayer's-Bach's hyperplasia, which is usually associated with viral infection or with the rotavirus vaccine. The rotavirus is responsible for most cases of viral gastroenteritis in childhood. Also, another cause in this age group is Meckel's diverticulum, which is a diverticulum that is located in the ileum, and it is a congenital diverticulum. These areas of Bayer's-Bach's hyperplasia or Meckel's diverticulum can be the leading point for starting the intussusception process. In older children or in adults, you have always to suspect an intraluminal mass or a tumor to be the leading cause of intussusception, because intussusception is not common at that age group. So whenever we see an intussusception in an adult, we should think of an underlying cause or mass or a tumor as the leading point for the intussusception. When we suspect intussusception, especially in the children under the age of 2, you suspect it when you receive a child to the emergency room complaining of abdominal swelling and distension, associated with vomiting and passing of stools that are mixed up with blood and mucus, and it is typically called a currant jelly stool. This is a typical description for the appearance of the stool in these patients. So a patient in the emergency room, he's a kid with abdominal swelling and distension, vomiting, and passage of blood and mucus colored mucus mixed stools. If the patient is older, he can complain of pain, but in the case of patients under the age of 2, the pain is usually expressed by continuous crying and grunting. So when you see these symptoms in a kid under the age of 2, you should have a high index of suspicion for intussusception, because an early identification of the case and early management will save the patient. How it is managed in early uncomplicated cases, or idiopathic cases, the disease can be diagnosed and managed with the same procedure, a contrast enema أو ما نسميه بالحقنة الشرجية. نحقن حقنة بcontrast media through the rectum, and this enema will reduce the intussusception. So it is like therapeutic and diagnostic at the same time. However, in complicated cases, complicated by infarction, or in cases in older adults or older children in which there is a leading point for the intussusception, surgery is indicated in those cases. So as I said, the early diagnosis is very important to is very important to save the patient life, to decrease the incidence of infarction, and for more easy management. One of the important causes of non-mechanical or functional obstruction of the large bowel is Hirschsprung disease. Hirschsprung disease is a disease that is characterized by a congenital, that is the baby is born with congenital defect in the colonic innervation, in the intrinsic nerves of the bowel wall. It is also called congenital aganglionic megacolon. Congenital because the disease is congenital, it presents after birth, and aganglionic because a typical feature of this disease is the absence of ganglion cells upon tissue microscopic examination, and megacolon due to the dilated colon proximal to the area of lost ganglion cells. So the name congenital aganglionic megacolon is a description of the disease process. The disease is more common in males, however, it tends to be more severe in females, and usually you have a family history. So when one family member is affected by Hirschsprung disease, the risk increases in his siblings or in his relatives. The typical presentation for Hirschsprung disease is it starts at the immediate postnatal period after delivery, and it is characterized by a neonatal failure to pass meconium. Meconium is the first stool that is passed after delivery of the fetus, and delay in passage of the meconium or failure in the passage of the meconium is an early feature that makes you suspect Hirschsprung disease. Later on, it is followed by a chronic obstructive constipation in the child, and no underlying mechanical cause is found, so the problem تعزى إلى functional obstruction, and then the workup to diagnose Hirschsprung disease is undertaken. So what is the pathogenesis of Hirschsprung disease? The pathogenesis starts during embryogenesis, in which there is a defect or a failure of migration of the neural crest cells from the cecum to the rectum. And so the result is lack of development of the neural plexuses that are usually present within the rectum. The disease affects the rectum in almost all of the cases. However, the length of the affected segment is different from one patient to another according to the severity of the disease. So the end result, due to failure of migration of these neural crest cells, is that a segment of the bowel will have absence of submucosal nerve plexuses and myenteric nerve plexuses. So we will lose the enteric nerve plexus or neuronal plexus at the affected site. And the result of this absence of these plexuses is lack of peristaltic contractions or lack of coordinated peristaltic contractions, which will result in the most important symptom of this disease, which is constipation due to lack of peristalsis. So at the end, we have an area of the bowel that lacks innervation by the enteric neuronal plexuses due to the failure of the migration of these neural crest cells from the cecum to the rectum during embryogenesis, and this segment will have lack of peristaltic contractions and the resultant constipation. Now, the familial cases of Hirschsprung disease, they share a mutation in the RET gene, and also this gene is mutated in a subset of the sporadic cases. Other genes are also implicated and some environmental factors. So again, the main feature of Hirschsprung disease is that we have a segment of the bowel that lacks innervation and lacks the development of the enteric neuronal plexuses, namely the myenteric plexus and the submucosal nerve plexus. And that's why the disease is called aganglionic, because we don't have the ganglion cells that are typical for these plexuses in the affected segment. In Hirschsprung disease, the rectum is always involved. However, the extent of the disease or the length of the involved segment of the bowel is variable, and it differs from one patient to another. Most cases are in the rectosigmoid area. However, in very severe cases may involve the entire colon. So the affected area with aganglionosis, in which we don't have ganglion cells, this area will look normal or contracted or on barium enemas. The proximal normal segment, normally innervated bowel segment, will undergo progressive dilatation. So we will have a megacolon in the normally innervated segment and a normal or contracted caliper in the aganglionic segment. You will see the barium enema in the next slide, in which you will see the contracted segment. The aganglionic segment will look contracted, and the normally innervated segment will look progressively dilated, like what we see in achalasia with progressive dilatation of the esophagus. Now, how we diagnose Hirschsprung disease? The diagnosis is a combination of clinical features, in which we have a child with a failure to pass meconium, for example, or a child complaining of a chronic constipation, in which we fail to find a cause for this constipation. The barium enema will help us in the typical characteristic feature of contracted aganglionic segment and a dilated normally innervated segment. But the gold standard for the diagnosis is the biopsy. Usually a rectal full thickness biopsy is used for diagnosis, in which we will establish the absence of the ganglion cells in the myenteric plexus and in the submucosal plexus. And this process is not easy, because usually we need to examine multiple deeper levels from the rectal biopsy to be sure that there is no ganglion cells, because when you say to the surgeon that this is Hirschsprung disease or you don't see ganglion cells in the biopsy, this will have a serious outcome on the patient. The patient will undergo resection of this aganglionic segment until we reach the area with normal innervation, and then anastomosis of the normal segment to the distal part of the rectum. So the diagnosis is not easy, and the gold standard for the diagnosis is the is the demonstration of the absent ganglion cells on the rectal biopsy. Here you can see the microscopic appearance of a Hirschsprung disease. You can see the contracted rectum and the progressively dilated proximal normal segment, and the adjacent picture illustrates the barium enema with a contracted rectum and a dilated proximal colon. These are the normal ganglion cells, which we keep looking for in cases with suspected Hirschsprung disease. The typical ganglion cell have an abundant eosinophilic cytoplasm and a centrically located nucleus with a prominent nucleolus. The absence of these cells in the myenteric nerve plexus and in the submucosal nerve plexus is needed to establish a diagnosis of Hirschsprung disease. What are the complications of Hirschsprung disease? Enterocolitis, because we have a stasis of stool in the bowel, and this will place the patient for the risk of enterocolitis, infectious enterocolitis. Also, there will be fluid and electrolyte disturbances, sometimes dehydration. The dilated megacolon is under the risk for perforation and peritonitis. The treatment, as I said, is resection of the aganglionic segment after being sure of the diagnosis, and anastomosis of the normal segments together. And the patients usually do well, but they need time to be adjusted to the to the new situation after the surgery. After discussing the intestinal obstruction, we move to vascular disorders of the bowel, which are divided into ischemic bowel disease, which is a result of ischemia, or loss or decreased blood supply to the bowel, whether it is acute or chronic. And usually ischemic bowel disease is seen in older subjects and old elderly patients. The second vascular disease, which is a common problem in outpatient clinics, is the hemorrhoids. The other vascular disorder of the bowel is the hemorrhoids. The hemorrhoids are dilated veins, submucosal veins in the anal and rectal mucosa. The pathogenesis of hemorrhoids is similar to the pathogenesis of esophageal varices. They occur in association also with portal hypertension, because, as I explained earlier, the anorectal area is the site of the portosystemic anastomosis or portosystemic shunts. So hemorrhoids are dilated veins in the submucosal location in the anal area or the rectal area. And the hemorrhoids are subdivided into internal hemorrhoids and external hemorrhoids according to the location. If it is below the anorectal line, it is called external hemorrhoids, and if it is above the anorectal line in the rectal mucosa, it is called internal hemorrhoids. The predisposing factors for hemorrhoids, as I said, portal hypertension is an important predisposing factor, with the causes of portal hypertension being like liver cirrhosis or schistosomiasis. Other causes, common causes of hemorrhoids, are the chronic constipation and straining, which will increase the intraluminal pressure within the rectum and cause dilatation of these veins. Also, venous stasis of pregnancy is an important cause of hemorrhoids. Being thin-walled and in a submucosal location places these vessels under the risk of rupture or abrasion and the resultant bleeding. So the symptoms of hemorrhoids is mainly bleeding, and usually the blood is fresh colored, red blood. If it is complicated by thrombosis or inflammation, the patient also will complain of pain. So hemorrhoids are typically associated with bleeding, with of fresh blood, and pain. So here we come to another important manifestation of intestinal diseases, which is called diarrhea. Diarrhea is defined as increase in stool mass, frequency, or fluidity. So any one of these is enough to call it diarrhea. Either increase in the mass or the frequency of passage of a stool or the fluidity of the stools. Another definition that you have to know is called dysentery. Dysentery is painful with مع ألم, bloody, small volume diarrhea. Diarrhea as a manifestation of intestinal disease can be caused by a variety of causes, and it is subdivided into malabsorptive diarrhea, infectious enterocolitis or infectious diarrhea, and chronic inflammatory bowel diseases. In addition, sometimes ischemic colitis can result in diarrhea and some nutritional deficiencies. But the most common causes are malabsorptive diarrhea, infectious enterocolitis, and chronic inflammatory bowel diseases. The infectious enterocolitis will be covered in the microbiology section, and we already covered inflammatory bowel diseases in a separate section. The malabsorptive diarrhea will be covered during this lecture, and the causes are diverse. It can be caused by pancreatic insufficiency, celiac disease, and Crohn's disease. And these three diseases are the most common causes of chronic malabsorption in the Western countries. Pancreatic insufficiency due to lack of pancreatic enzymes, and celiac disease, مرض تحسس القمح, and Crohn's disease, which is one of the inflammatory bowel diseases, as we mentioned in the CIBD lecture, which can result in malabsorption because it affects the small bowel and the terminal ileum, the site for absorption of many nutrients, especially vitamin B12, proteins, and albumin and bile salts. Another cause of malabsorptive diarrhea is cystic fibrosis, which is a disease called التليف الكيسي, cystic fibrosis. It is caused by a genetic mutation. Another cause of malabsorption is lactase deficiency, a common cause of diarrhea caused by deficiency of the enzyme needed for the digestion of the disaccharide lactose, سكر الحليب. And another cause is A-beta lipoproteinemia. So all of these are diverse causes of diarrhea, and they differ in somehow in their clinical presentation. So malabsorptive diarrhea is a chronic diarrhea. هي إسهال مزمن, and it is a result of the defective absorption of many nutrients like fat and water-soluble vitamins, proteins, carbohydrates, electrolytes, minerals, and water. So absorption of all of these substances can result in chronic diarrhea. The hallmark of malabsorptive diarrhea is called steatorrhea. Steatorrhea is the greasy, fatty, bulky, yellow-colored or clay-colored stools that is typical for malabsorption. The malabsorptive nutrients or materials are all are accumulated in the stool, and they gave the stool this greasy, fatty, yellow discoloration. So it is called steatorrhea, and it is the hallmark of malabsorptive diarrhea. The mechanisms by which malabsorptive diarrhea develops is due to a defect in one of the following functions. It is either a defect in the intraluminal digestion of the large nutrient substances like fats, carbohydrates, and proteins, and usually this is as a result of the main enzyme deficiencies like pancreatic deficiency. So defect in the intraluminal digestion of the large molecules. The second defect is in the terminal digestion, the digestion of the terminal of the end products of the carbohydrates or the proteins like the small disaccharides or the small peptides, which is usually associated with deficiency of some disaccaridases and peptidases, which are usually seen at the brush border of the small intestine, like lactase deficiency. The other defect is in the transepithelial transport of the nutrients through the epithelial cells in order to reach the other side, or the vascular side. And the last defect is in the lymphatic transport of the absorbed lipids, because absorbed lipids usually are transported through the lymphatics to the systemic circulation. So any defect in one of these steps, the intraluminal digestion, terminal digestion, or transepithelial transport, or lymphatic transport, can result in malabsorption. And in fact, sometimes more than one mechanism can act at the same time. Now, the manifestations or the clinical signs and symptoms of malabsorption differs according to the substance that is being malabsorbed. But in general, all malabsorptive diseases share common manifestations. One of the most important manifestations is weight loss. Due to the lack of absorption of proteins and carbohydrates and fats. Anorexia, it is loss of appetite. So malabsorptive diseases can result in loss of the appetite. Another manifestation is flatus or abdominal gaseous distension. This is a common manifestation of malabsorption because of due to the malabsorption of disaccharides or carbohydrates. These materials stay in the intestinal lumen, and the normal flora and the bacteria acts upon them and causes their fermentation with the production of gases, and this will result in abdominal gaseous distension. Another manifestation is borborygmi. Borborygmi اللي هي الأصوات اللي ممكن نسمعها للمعدة والأمعاء due to the presence of gas within the bowel lumen. And also muscle wasting. Muscle wasting, in which the main muscles, they look like atrophied. We call it muscle wasting. Another manifestation is the anemia and mucositis, and the anemia can be caused by iron deficiency or vitamin B12 deficiency or folate deficiency. Mucositis, which is inflammation of the mucous membranes at the angle of the mouth, and also it can be caused by iron deficiency, folate deficiency, and the vitamin B6 or pyridoxine deficiency. Also, deficiency of the fat-soluble vitamins like vitamin K can result in a bleeding tendency, because vitamin K is needed for the thrombotic cascade. And the deficiency of vitamin K can result in bleeding, nazif. Also, malabsorption of calcium, magnesium, and vitamin D can result in osteopenia ونقص في كثافة العظم وأحيانا osteoporosis وهشاشة عظام على عمر مبكر in addition to tetany. Malabsorption of vitamin B12 and vitamin A can result in neuropathy and neurological manifestations like peripheral numbness, خدران في الأطراف, or burning sensation in the hands and feet, and also muscle weakness. Also, skin and endocrine disorders can result from the malabsorption of substances that are needed for the skin development or and for the hormone synthesis, like deficiency of iodine, or malabsorption of iodine can result in the thyroid hormone deficiency. Cystic fibrosis is one of the diseases that cause malabsorptive diarrhea. Cystic fibrosis أو بيسموه التليف الكيسي. It is a multi-organ system disease with a genetic basis. So the disease affects the lungs, affects the pancreas, and affects the intestines. And the main genetic defect in the CFTR, which is called the cystic fibrosis transmembrane conductance regulator. Mutations in this gene can result in a defect in the ion transport across the epithelium of the intestine and across the pancreatic epithelial ductal cells. And due to the defect in the ion transport, and you know that always the movement of ions like sodium is accompanied by movements of water. So when there is defect in the transportation of sodium across these membranes, water will not follow the sodium, and the secretions from the pancreas will be highly viscous and high and thick secretions, which can cause mucus plugs within the pancreatic ducts, leading to blockage of these ducts, and the pancreatic enzymes will not reach to the intestine, so causing pancreatic insufficiency in 80% of patients with cystic fibrosis. The result of pancreatic insufficiency is defects in the intraluminal digestion, and the end result will be malabsorptive diarrhea. One of the most important diseases that cause malabsorptive diarrhea is celiac disease أو حساسية القمح. It is also called gluten sensitive enteropathy, and this disease is an immune mediated enteropathy due to sensitivity against the gluten material, which is present in many cereals like the wheat, rye, and barley. It is present في القمح والحنطة والشعير. This disease occurs in genetically predisposed individuals who carry the HLA-DQ2 or HLA-DQ8 genes. The typical treatment for celiac disease is a gluten-free diet, which is, it's not an easy diet to stick with because gluten is present in so many cereals. موجود في الخبز، موجود في البسكوت، فموجود في كل منتجات القمح، حتى المواد، بعض المواد المعلبة والكاتشب كثير من كثير من المواد الغذائية تحتوي على الجلوتين. So it's not easy for the patient to stick for the gluten-free diet, but it is the typical or the standard therapy for celiac disease because patients' symptoms will improve dramatically upon withdrawal of gluten from their diet. من الجدير بالذكر إنه celiac disease is commonly associated with other autoimmune diseases. As I said before, autoimmune diseases tend to cluster together most of the time. So a patient who have celiac disease, there is a high possibility that he also has type 1 diabetes mellitus or certain types of thyroiditis like Hashimoto thyroiditis and Sjogren syndrome. Celiac disease develops in a genetically predisposed individual. The genetically predisposed individuals should carry the HLA-DQ2 or HLA-DQ8 phenotype. So all of us are exposed to gluten, but not all of us will develop celiac disease. Those who develop the disease should carry the HLA-DQ2 or DQ8 alleles on the surface of their antigen presenting cells. So the disease starts with exposure to gluten. Gluten is digested by the intestinal enzymes into the short peptide called gliadin. Gliadin is resistant to the digestion by the gastric and intestinal or even pancreatic enzymes, and this gliadin is usually deamidated by an enzyme called tissue transglutaminase enzyme. The deamidated gliadin then enters to the lamina propria of the small intestinal mucosa and reacts with the HLA-DQ2 and the HLA-DQ8 on the surface of the antigen presenting cells. This binding between the gliadin and the HLA-DQ2 or DQ8 will result in activation of T cells, principally the CD4 positive T cells. This activation of these T lymphocytes will lead to the production of cytokines, and these cytokines are responsible for the tissue damage that is associated with celiac disease. The main tissue damage is associated with loss of the villus architecture of the small intestine and loss of the epithelial cells lining the intestinal mucosa, leading to decrease in the surface area that is exposed for the absorption of nutrients, and the end result will be malabsorption of nutrients due to loss of this villus surface of the small intestine. So the pathogenesis of the disease involves the tissue damage provoked by the inflammatory mediators and cytokines that are released by the T lymphocytes. Then the antibody response also starts with the production of certain antibodies like the anti-tissue transglutaminase antibody and the anti-gliadin antibody and the anti-endomysial antibodies. Actually, it is not known whether these antibodies are the cause of the disease or they are produced in response for the entrance of gliadin, and the starting point is still a controversial issue. But these antibodies are very important in the diagnosis of the disease, so they are diagnostically useful, and also they can be used for monitoring the response for a gluten-free diet. These antibodies are supposed to decrease or to return back to normal levels after gluten-free diet for 3 to 6 months. These antibodies are supposed to decrease after or to fall after 3 to 6 months of a gluten-free diet. So again, this diagram illustrates the pathogenesis of the disease, the pathogenesis of celiac disease. You can see to the smaller picture to the left of the slide, there is loss of the villi. The villi are very important to increase to the surface area for absorption in the small intestine. Celiac disease typically show loss of the villi in variable degrees. The loss can be subtotal or total loss of the villi with flattening of the mucosa, or sometimes it's just shortening of the villi early in the disease. So the degree of loss of the villi or shortening of the villi is related to the severity of celiac disease. The disease starts with the exposure to gluten. Gluten is the protein that is present in wheat, and we are all, as I said, exposed to gluten, but not all of us develop celiac disease. It develops only in a genetically predisposed individual. So gluten is divided or digested to gliadin by the action of intestinal enzymes, and gliadin is a highly resistible small peptide. It is resistant to the action or to the digestion by the pancreatic or the gastric or the intestinal enzymes. What happens is that this gliadin enters through the epithelium to the lamina propria, and there it undergoes what is called deamidation. Deamidation by the action of tissue transglutaminase enzyme. This deamidated gliadin later on reacts with HLA, DQ2 and DQ8 on the surface of antigen-presenting cells. So if the patient is not genetically predisposed and does not carry the HLA, DQ2 or DQ8 alleles, then the gliadin will not react with these antigen-presenting cells, and there will be no consequences to the entrance of gliadin. When the gliadin binds to the HLA, DQ2 or DQ8 on the surface of the antigen-presenting cells, ABC, there will be a lymphocytic reaction predominated by CD4 positive T helper cells. These activated T cells will release cytokines, and these cytokines will aid in the damage that is exerted on the epithelial cells, and will lead to attraction of lymphocytes, mainly CD8 positive cytotoxic T lymphocytes, to the epithelial cells. What we call it intraepithelial lymphocytes. So the lymphocytes in the lamina propria are mainly CD4 positive T helper cells, while the lymphocytes that are located in the intraepithelium, as you see here in the slide, are mainly cytotoxic CD8 positive T lymphocytes. These lymphocytes will cause damage to the surface epithelium and loss of the villus architecture that is typical for the small intestine. This loss of the villus architecture will lead to the malabsorption. Also, you can see the B cell or the B lymphocyte response with the production of antibodies, and these antibodies, as I said, it's not known whether these follow their production follows the exposure to gliadin, or they are produced prior to the exposure to gliadin and they cause the disease. The issue is still controversial. However, patients with celiac disease will show elevations of their anti-gliadin antibodies and anti-endomysial antibodies and anti-tissue transglutaminase antibodies. These three antibodies are diagnostically useful because they can be used to diagnose the disease. They are not elevated in all patients, but they can be used in the diagnosis, and also they can be used for the follow-up. So after you diagnose a patient with celiac disease and you place the patient on a gluten-free diet, after 3 to 6 months, these antibodies are supposed to fall, as well as the symptoms are supposed to disappear. So they can be used to monitor the disease activity, and they can be used to diagnose celiac disease. So after talking about the pathogenesis and the mechanism by which celiac disease develops, here we come to the morphology of the disease in the small intestine. The main parts that are affected in celiac disease are the second part of the duodenum and the proximal jejunum. So if we want to diagnose celiac disease, the endoscopist or the gastroenterologist should take a biopsy from, it is preferably to take a biopsy from the second portion of the duodenum or the proximal jejunum, and it's preferable to take multiple biopsies to increase the diagnostic yield. We usually try to um, um, not to, we usually try not to take biopsies from the first part of the duodenum, because usually it is exposed to damage exerted by the acidic gastric juices. So to overcome this effect, we recommend that the biopsy being taken from second part of the duodenum or proximal jejunum. What we see in celiac disease is a triad of intraepithelial lymphocytosis, and these lymphocytes that are present within the surface epithelium are usually CD8 positive T lymphocytes. The second part of the triad is hyperplasia of the crypts with increased mitotic activity, and this is as a result of the increased damage and turnover of the intestinal epithelial cells. The third part of the triad is villus atrophy with variable degrees ranging from just shortening of the villi to subtotal villus atrophy to even total villus atrophy with flattening of the mucosa and loss of the surface area that is exposed to the absorption of nutrients. So this is the triad of celiac disease. Intraepithelial lymphocytosis, which is considered the earliest manifestation of celiac disease, even in the absence of a crypt hyperplasia and villus atrophy. In the lamina propria, we will see influx and infiltration by lymphocytes, which are mainly CD4 positive lymphocytes, plasma cells, and many eosinophils. However, the intraepithelial lymphocytosis and the villus atrophy that are seen in celiac disease are not pathognomonic, because we can see villus atrophy in cases of viral enteritis. So the diagnosis of celiac disease is not only a histologic diagnosis. We should take the patient as a whole. We should take the clinical history, the serologic findings, and the presence of antibodies in the serum, in addition to the histologic picture. So we correlate all of these information together to get up with a diagnosis of celiac disease. And the most important feature also is when we place the patient on a gluten-free diet, the patient should respond and the symptoms should disappear. So this is an important hint that this is a celiac disease. So celiac disease diagnosis is not only a histologic diagnosis, it is a clinical, serologic, and histologic diagnosis. So you can see here a comparison between the normal villi of the duodenum to the left and the mucosa of the duodenum in a patient with celiac disease. So you can see the villi, elongated villi, and the other picture in a patient with celiac disease, there is no villi, there is total loss of the villus architecture with a flattening of the mucosa and infiltration of the lamina propria by many lymphocytes, plasma cells, and even eosinophils. So this is the typical appearance in a patient with celiac disease. But as I said, the diagnosis is not only histologic. Patients with a gluten-free diet on follow-up typically show a reversal of the changes and regaining of the normal villus architecture after gluten-free diet. Celiac disease can affect adults as well as children, and typically the disease starts in children after 6 months of age, which is after the introduction of food and cereals to the diet of the kid. It can present with the classical or non-classical symptoms. The classical symptoms of celiac disease in a kid includes irritability. The patient is irritable. He is not the baby is not calmed down. Abdominal distension due to the malabsorption, gaseous distension, and loss of appetite, and the typical presentation with diarrhea or steatorrhea. Failure to thrive is an important manifestation of celiac disease in kids. That is, failure to gain weight due to the malabsorption of carbohydrates and proteins, and the decrease in the metabolic or anabolic functions of the body. Also, sometimes weight loss or wasting of the muscles. So all of these are classical symptoms. However, some kids or some children, they present with non-classical manifestations which can delay the diagnosis sometimes. That is abdominal pain, nausea and vomiting, or bloating, or even constipation. A patient with malabsorption is supposed to present with diarrhea. However, those non-classical presentations in children can involve constipation rather than diarrhea. So we should always have a high index of suspicion for any case of celiac disease in children. In about 10% of patients, the celiac disease, either in adults or in children, is associated with a blistering, itchy skin lesions that are called dermatitis herpetiformis. بيشبهوا فيروس الهربس اللي ممكن to infect the skin. So it is called dermatitis herpetiformis. لها strong association with celiac disease. However, it just occurs in about 10% of patients. So these are the typical lesions of dermatitis herpetiformis. You can see here the vesicles and the blisters on the skin that are highly itchy. And as I said, it is an associated feature with celiac disease. It is not an infection with herpes virus, but it looks like the herpetic vesicles that are seen with herpes virus infection. In adults, the disease typically presents between the age of 30 to 60 years. The typical presentation is with malabsorption. Anemia, that is typically iron deficiency anemia, because the duodenum and the proximal jejunum are the main sites for the iron absorption. Vitamin B12 and folate deficiency anemias are less common because, as you know, the vitamin B12 and is being absorbed in the distal small intestine, principally in the ileum, which is usually not affected in a patient with celiac disease. The main classical symptoms in an adult is abdominal gaseous distension, weight loss, muscle wasting, diarrhea or steatorrhea, bloating, and fatigability, usually due to the iron deficiency anemia. However, sometimes the diagnosis of celiac disease can be missed or can be delayed due to a silent disease or a latent disease. A silent disease means that a patient have a positive serology for the celiac, and if we do a biopsy, he will show villus atrophy. So we have a histological diagnosis and a serologic diagnosis. However, the patient is asymptomatic, but meanwhile, maybe later on the patient will start to develop or to complain of the symptoms of celiac disease later on. Latent disease, it means that the patient have a positive serology. However, histology is normal and symptoms are absent. And this is called latent disease. These cases of silent disease or latent disease may develop the full-blown picture of celiac disease later on. The most important in patients with celiac disease is that they have an increased risk of certain type of lymphoma, which is called enteropathy-associated T-cell lymphoma, and even there is an increased risk of small intestinal adenocarcinoma. adenocarcinoma. So a patient with celiac disease have an increased risk of lymphoma and small intestinal adenocarcinoma. How to diagnose celiac disease? Like any disease, the diagnosis of any disease needs a good clinical history, then physical examination of the patient, then the diagnostic evaluation, including laboratory investigations, and imaging studies, or even histopathologic studies. And regarding celiac disease, when we suspect celiac disease in a patient who presents with weight loss, abdominal distension, muscle wasting, and for example iron deficiency anemia, we should think of celiac disease. And first we start with the non-invasive tests, which are called non-invasive serologic tests, the antibodies that we talked about them in celiac disease. The most sensitive antibodies are the anti-tissue transglutaminase antibodies, which are IgA antibodies, and the anti-deamidated gliadin antibodies, which are IgA and IgG antibodies. Those antibodies are highly sensitive, but they are not specific. The most specific antibody is the anti-endometrial antibody, but the problem is with anti-endometrial antibody is that it is less sensitive. So a combination of all of these antibodies is the best practice to do to diagnose celiac disease. Then the more invasive tests follows with a upper endoscopy and a small bowel biopsy, preferably from the second part of the duodenum or the jejunum, and microscopic examination for the triad of the features, triad features or triad findings that we talked about them, including intraepithelial lymphocytosis, villus atrophy, and Krebs hyperplasia. When we diagnose the patient with celiac disease, the best treatment or the current treatment is gluten-free diet. Gluten-free diet will result in a reversal of symptoms, a disappearance of symptoms, and even a fall in the antibody levels, and even a reversal of the changes on the small bowel biopsy. Sometimes because of a non-adherent diet or a non-restricted diet, the patient may have relapses. And the most common cause of relapses in celiac disease is that the patient is non-adherent to the gluten-free diet. After after a long period of treatment for celiac disease with the gluten-free diet, if the patient develops a resistance or refractory symptoms that are resistant to the gluten-free diet, we should start to think about a lymphoma transformation or adenocarcinoma transformation. The first signs of a lymphomatous transformation is the loss of response to the gluten-free diet. So here we come to another cause of malabsorptive diarrhea, which is the lactase deficiency, disaccharidase deficiency. What is lactase? Lactase is the enzyme that is responsible for cleaving the lactose sugar, اللي هو سكر الحليب. Where it is present? It is present at the apical brush border membrane of the small intestine. So the result is of lactase deficiency is the accumulation or build-up of lactose in the gut lumen. And this lactose in the gut lumen will absorb water with it, causing an osmotic diarrhea. The typical for this osmotic diarrhea is that it abates when withdrawal from milk and milk products is undertaken. So when the patient is ينقطع عن الملك and the milk products that contain the lactose sugar, the symptoms will abate and the diarrhea will disappear. Typically, these patients show a normal biopsy finding. So a biopsy from the small intestine will be normal because the problem here is an enzymatic deficiency. It is at the biochemical level, which cannot be reflected by any microscopic abnormality. We have two types of lactase deficiency. The first one is congenital and the second is acquired. The congenital is rare and it is autosomal, it has an autosomal recessive pattern of inheritance, and it is due to a genetic mutation in the lactase enzyme. Those patients will start to complain or to show symptoms of explosive, very severe watery diarrhea with frothy stools and abdominal gaseous distension after milk ingestion. The acquired lactase deficiency is common, and usually it follows viral or bacterial gastroenteritis, which lead to the damage of the apical brush border of the small intestinal epithelium with loss of the lactase enzyme, or sometimes it is due to the downregulation of the lactase gene that is responsible or coding for the lactase enzyme. Usually this happens after childhood, after the need or the necessity for milk ingestion decreases. So the acquired form is more common than the congenital form. And the treatment for lactase deficiency is to is lactose withdrawal from diet, and this is typically done by تجنب كل الأطعمة اللي تحتوي على اللاكتوز like milk and milk products. A-beta lipoproteinemia is another malabsorptive disease which is autosomal recessive and very rare. Typically, from its name, A-beta lipoproteinemia, it means the absence of beta lipoproteins in the blood. And the absence of these beta lipoproteins is due to a deficiency or lack of the absorption of fat and fat-soluble vitamins. The main problem in A-beta lipoproteinemia is the inability to secrete triglyceride-rich lipoproteins due to a epithelial transport defect of the triglycerides and fatty acids. So the triglycerides and fatty acids enter the epithelial cells of the intestinal tract. However, they cannot be transported to the blood or absorbed to the blood. So the result is deficiency of these triglycerides and fatty acids and deficiency of fat-soluble vitamins, and the body cannot form or synthesize the triglyceride-rich lipoproteins. So the result is defects in the vitamin absorption and a defect in the lipoprotein synthesis, which is an important part of the cell membranes of many cells. These monoglycerides and triglycerides, which are not being absorbed to the blood, accumulates within the epithelial cells, which can result in the typical microscopic appearance in these patients of fat globules seen in the epithelial cells of the small intestine. These patients are usually infants and they present with failure to thrive, they fail to gain weight and fail to grow, associated with severe diarrhea and steatorrhea. So this is the typical microscopic appearance that is seen in this rare autosomal recessive disease, and it is characterized by the appearance of clear cytoplasm due to lipid accumulation, as you can see on the surface epithelial, in the surface epithelial cells lining this part of the small bowel. The cytoplasm looks clear due to accumulation of fat droplets or fat vacuoles within these cells, because the fat enters to the intestinal epithelial cells, but it cannot be transported to the blood due to the defect in the secretion.